So now it's time to work on the hamstrings. And first off, we're going to start with some general massage, some petrissage. And we're going to find the area where the scar tissue is. Typically where the hamstrings will tear is right in here by the ischial tuberosity. And scar tissue is not difficult to find because usually it will feel lumpy, feel like a lump in the muscle. And it often feels tender to the client. That feels like that there. How's that feel, Benny?
Sore.
Sore. Okay, good. So we found it. So now I go in deep, fairly deep on this. It should be within the client's comfort range. And we go back and forth slowly over the side of the scar tissue, spreading it out. The idea is to break up any adhesions between the muscle fibers, but we're leaving the scar tissue that goes parallel with the muscle fibers. And so this is done fairly slow and deep. And we can do this up to 5 minutes or so. And we would do this about once a week, once to twice a week. But you don't want to do it more than every few days because it can cause some inflammation. Then after the 5 minutes of working on it, we can apply ice to the area to keep the inflammation down. And we'll leave the ice on for 5 to 10 minutes, long enough for it to get to the numb stage. And then after using the ice, we can do some general massage again, smooth everything out. Now what Benny can do for this herself is also to do exercise at the gym, doing leg curls, which will work out the hamstrings, following it up with ice to the area. And she can do that on times in between the treatments that I do. And that will also help break up the scar tissue and facilitate faster healing. Besides the cross fiber work, we can also do therapeutic exercise to help with the hamstring tear. We'll have Benny doing leg curls, doing 3 sets of 10, where she'll start to feel it in the last set of 10. If she feels it sooner, that means that there's too much weight. If she doesn't feel any stress at all with it, then she needs a little more weight. So it should be felt in that last set of 10. Also, we will follow the exercise with an application of ice because the exercise can get the area inflamed, and we always want to keep the inflammation down. And the ice is on just for 10 minutes, just long enough to get the area numb. Some authorities suggest having a cloth between the ice pack and the skin. I've never known that to be a problem, but I think it depends on the coldness of the ice pack and on the client's sensitivity. Tennis elbow is also called lateral epicondylitis or extensor tendinitis, and that's because it's an inflammation of the extensor tendons near the lateral epicondyle of the humerus. And it's often caused by an improper backhand in tennis. I'm told that it's often from moving the wrist when doing the backhand. So one of the first things that we need to do with a person with tennis elbow is make sure that they get help with their tennis game to learn proper form with it. There's a simple way to test for tennis elbow, and that is to have the client try to extend their wrist against resistance. Go ahead and extend your wrist. And if this causes pain near the lateral epicondyle, that's indicative of tennis elbow. There's another problem that can occur with the flexor tendons called golfer's elbow, and we can test for that by having the client try to flex against resistance, and it will cause pain here near the medial epicondyle. Golfer's elbow, of course, can be caused by golf, but you can also get it from racket sports, from improper forehand or serve. The way we would treat tennis elbow is to use deep cross fiber work right at the area of pain. Maybe some scar tissue in this area, and we can go in fairly deep, and we do it with the muscle in a relaxed position. Is that tender in there?
Mm-hmm.
Okay. So we go back and forth slowly right over the spot. And we can do that for up to 5 minutes, staying within the client's comfort range. And then follow that with ice to the area. Other treatment that we can do for it would include doing exercise using hand weight and also stretches. Now for tennis elbow, it's important to build up the muscles as well, so we'll use a hand weight doing wrist extensions, doing 3 sets of 10 where it's felt in the last set of 10. The idea is to strengthen the muscle so that it won't tear so easily. Once the exercise is completed, we apply ice to the area, again to keep the inflammation down. Another technique that can be used for tennis elbow is from soft tissue release with Stewart-Tawes. What we do is press into the affected area, and since these muscles are extensors, what we're going to do is hold it in a shortened position and then lengthen it by flexing the wrist and also by pronating. So we press in, flex, and pronate all along the length of the muscle. And we can do that specifically with the thumb, pressing right into the affected muscle. And we can also do it with the thumb flat, so you're getting the whole muscle group. Rotator cuff muscles are a group of 4 muscles that help to hold the head of the humerus into the shallow socket of the glenoid fossa of the scapula. And these muscles get torn anytime the shoulder is dislocated. This can happen suddenly in an accident or injury where there's frank dislocation, or it can happen with repeated microtrauma, say with a baseball pitcher. When they pitch a fastball, the humerus can temporarily leave the socket, and you can get tearing of the rotator cuff fibers. Oftentimes with athletes, they won't complain about the pain until they start noticing a loss of function. But by then, significant injury has happened. Now, when we go to work the rotator cuff area, we need to know which muscles are involved. Earlier, we did an assessment of shoulder pain, and using those assessment techniques, we can help to determine specifically which muscles the problem would be in. Let's assume for now this problem in the supraspinatus. The way that we can work that is put the client's arm behind their back. This exposes the supraspinatus muscle a little more, and we'll find it in this notch between the clavicle and the scapula. The problem typically will be further out on the distal end, out toward the acromion process. A client can have what's called supraspinatus tendinitis, and it will feel a little tender there, and it can feel a little lumpy if there's scar tissue there. So you can work in deep. I find it's about wide enough to get a fingertip in there, and you can go back and forth fairly deep into this area, doing cross-fiber work. After doing that for about 5 minutes, it can be followed with ice. I worked with a bodybuilder that had a supraspinatus tendinitis from an injury, and we were able to track his progress with the weightlifting because he was able to see how much he could lift each week, and it increased every week, and we knew that he was completely healed when we got him back to where he could lift what he could before. Now, other areas that can get injured would be the infraspinatus and teres minor, and these we can work. I find oftentimes the lesions will either be right along the axillary border of the scapula, sometimes along the back of the scapula, and sometimes at their attachment on the humerus. But you can find where the tender spots are, where the scar tissue is, and work into it with deep cross-fiber work going across the grain of the muscle. And again, follow it with ice. And then if the problem's in the subscapularis, you can get in under the front border of the scapula, under the axillary border in front, with some cross-fiber work. And I find also I can work the muscle as a whole by moving the shoulder over the back. And what I do is I'll put the heel of one hand at the axillary border, heel of one hand at the superior border, fingertips around the medial border of the scapula, and then move the scapula over the rib cage like this. And I do this by moving my whole body. And I'm careful to keep Benny's arm up above her head. This way the scapula is pressed into the back. If I don't do that, it doesn't feel as firm, and if I do it right, I can get Benny to slap her face. So after working these areas, we can apply ice, and we can also use therapeutic exercise to help speed the healing. Now for rotator cuff tears, we can also do therapeutic exercise. And if the problem is the supraspinatus tendinitis, we would have Benny doing an exercise involving abduction, using a weight where she can do 3 sets of 10 and that she would feel it in the last set of 10. After doing the exercise, we would apply ice to the area to keep the inflammation down. Shin splints can happen from overuse, and it happens particularly with runners running over 30 miles a week or runners running on hard surfaces. And one of the first things we need to do with an athlete with shin splints is to get them to rest. Now, in medicine, shin splints is considered a wastebasket diagnosis in the sense that there's about 5 different conditions that can cause pain in this area and that can be termed shin splints. You can have a myositis or tendinitis, which is inflammation of the muscle or tendon. You can have muscle or tendon tears. You can have a periostitis, an inflammation of the periosteum, which is the covering of the bone. You can also have stress fractures, which is hairline fractures in the tibia. And you can have what's called compartment syndrome, which is the thickening of the fascia around the muscles that will tend to block circulation in the muscles and cause pain. There are ways of telling the different causes of shin splints. One way, for instance, to tell about stress fractures is an X-ray, but X-rays are not always that accurate with it because the fractures are so small. Another, more low-tech way to determine this is to use a tuning fork. You get the tuning fork vibrating and then place it on the tibia. And if there's a stress fracture, it can be very painful for the client because it'll get that broken end of the fracture vibrating against the other end. So that's a way to tell, to determine fairly quickly if there's been a stress fracture. Now, for most cases of shin splints, I find it will either be a periostitis or a tendinitis myositis of the tibialis anterior and sometimes peroneus longus and brevis muscles. And the way I like to work that is with some massage techniques. I'll use a little bit of oil, turn the leg inward like this, and working with the heel of the hand, work up the calf like this. In this position, the muscle's stretched out, and I'm pushing the tibialis anterior right into the bone. At times, I'll also get in with the thumb right up to the edge of the bone here. And for deeper work, I can get in with the forearm. This work can be followed with ice. Another technique you can use for shin splints is from British Sports Therapy or soft tissue release techniques with Stuart Tawes, and that involves pressing into the tibialis anterior and then stretching the muscle while pressing it. And you can use your thumb and work all down the length of the tibialis anterior like this, or you can use the heel of the hand and get the peroneal muscles as well.